thank you very much, David and everyone, for inviting me to the Collaboration Centre and allowing me the chance to speak to you and discuss something very interesting with you. I share your pain, David, now, and I'm terrible at saying no as well. But in this case, I was very happy to say yes, because I think it's a really fascinating area for me to get involved in. I've been a health economist for 20 years. I probably got involved in mental health and then mental health and wellbeing more broadly about 10 years ago, after working more in things like chronic disease, cancer screening, the physical health domains. And the first thing I'd say is that it's blooming difficult and challenging working in mental health and wellbeing, but also that's the sort of thing that some of us sort of, it just, it makes it very enjoyable as well, and it's nice to be out of maybe our comfort zones and to think through more conceptually what we're doing and why. And I guess that's part of what I want to talk about today. I've got this title, but really I want to share some sort of thoughts about what we maybe as health economists can offer people interested in promoting public mental health and wellbeing, but also try and show some of the gaps in certainly my personal knowledge and perhaps our knowledge as a profession, so you can jump in and maybe beat us up a little bit, but also then improve us and make us better collaborators with you all. So what I'm going to talk about today is I'm going to start with something that I guess will be not controversial in this audience, that we probably do underinvest in terms of public spending, and maybe personal spending too, in well-being. And I'm going to use the term well-being here as a kind of placeholder for public mental health and wellbeing. I'm assuming that what I'm going to talk about will translate across that concept, but I'm also very happy I apologise if I'm totally misrepresenting and confusing concepts, and I'm very happy to be corrected on that. But I'll use wellbeing as my term for the topic at hand for this presentation. So I'm starting with this. I'm not seeing anyone looking shocked at this assertion that we underinvest as a society and as people in our wellbeing. Okay, I'd like to start fairly uncontroversially. So if we want to rectify that does clearly imply diverting resources from somewhere else. And that's kind of, there's an analytical, that's an analytical problem then, which health economists can contribute to as a discipline. But it's also a political question, obviously, which you'll understand better than me. So part of this is about thinking through the conceptual underpinning for justifying increasing investment, and inherently the same thing, diverting investment from somewhere else, but also maybe thinking through making the case to people who have the power to make that change. So I guess I wanted to make that point straight at the start, because I don't think you can divorce them, although as economists we tend to just pretend we're being analytical and politics is someone else's problem. But I don't think you can really divorce those things. I want to talk about, so I'm going to talk a bit about that and how we might make that case and how health economists might help. I want to say, we talked about counting, and I'm going to use three words again, maybe probing around some concepts here. I'm going to, in my view, I like to distinguish between three separate things that sometimes get muddled or over sort of merged together, and they shouldn't be. Identifying impact, measuring your impact, and valuing your impact. And I'll say a bit more about why I think those are important distinctions to make. I want to share a bit of very, very brief overview. This isn't going to be an introductory health economics lecture or anything like that, or even an advanced one. I want to talk a bit about some of the methods that may be relevant to, that being maybe used more in physical health, that could be expanded to mental health. And talk about maybe where they may be useful with our kind of policy change the world hats on, as much as our conceptual academic hats on. So how could we as health economists produce things that are valuable to you to help make the case that you know needs to be made and you want to make? So that's basically the route map of what I'm going to talk about. So the first thing I want to say, and I don't think I'm going to say anything particularly earth-shattering, and probably telling you lots of things you already know. And the first thing, obviously, I'm going to say is that what's important about well-being, and maybe why we underinvest in it, is this huge, diverse breadth of impacts improving well-being can have. And this is an overview that a diagram I've created based on largely a really nice summary by Prof. Layard at LSE, who's done a lot of work in terms of well-being and happiness economics. So in that paper, he summarised a lot of the academic literature showing this diverse range of impacts. So if you improve people's well-being, their health tends to improve, and there's some really interesting research showing that. So improving immediate well-being, long-term, things like cardiovascular disease, diabetes all improve. Educational achievements, I mean, obviously, if children feel, if their well-being improves, their educational achievement tends to improve. Linked to that, I guess, is productivity. Workers who have good well-being tend to be more productive. And this concept of pro-socialisation, I guess the idea that generally, I guess it's the flip side of saying that often a lot of crime and dysfunction isn't rooted in evil. I might say I'm straying well off my territory here as other columnists in theology, but it is probably more rooted in poor well-being, particularly in early childhood. I would, again, certain things aren't really my domain, but I think that's the idea. So if you improve well-being, there's a long-term benefit for others and for society. So one thing you might expect me to then say as an economist is, okay, well, then that leads to lots of knock-on effects, that financial effects. So, for example, we could save the NHS a lot of money if we improve health through improving well-being. Similarly, if children are better behaved at school, that we saves a lot of time, resources, and money in the schools. The economy will benefit if workers are more productive, and also we avoid a lot of very costly interactions with the justice system if we become more pro-social. So what that basically suggests is there's huge potential broad benefits from improving well-being in the short term in terms of the breadth and the time horizon of those impacts. That maybe creates, to come to this topic of measurements, so there's your challenge right there. How do we go across all these different areas and for all these complex causal knock-on effects? Because we want to get the full picture, to get the full value, to make that investment case I alluded to at the beginning. So I'll just say in kind of stuff, I won't go into detail about the methods, but we kind of have that experience in other areas, particularly chronic illness. And there are various analytical tools and techniques we can use to try and generate the estimates of complete and long-term benefit across that system picture I drew. So we have the tools to help to try and calculate that. And I think, coming back to this issue of measurement and interpreting it in terms of not just what we measure, but where we go and measure it, we don't need to measure everything. Maybe we can focus on measuring the things we know that are going to change, or the things that we know are important. And then we can then use these modelling approaches, which are basically synthesis tools. They're ways of synthesising what you've learned empirically with what you know as an expert, or what the literature can tell you. So we can use these tools to maybe help us focus on what we measure and then what we infer. I should have said, I meant to say at the beginning that I'm happy to take questions, comments, dissenting opinions, anything like that. Just, as Maher said, just put your hand up and let me know if you'd like to comment on anything I'm saying. So that gets us this idea of, well, maybe we can be efficient in what we measure, and we don't need to measure everything. We don't need to measure the thing we're ultimately interested in. We need to maybe measure the thing that we know will change. That's one concept. So I want to take that idea a bit further and think about what we're measuring, and some thought. We've written a paper with a kind of methodological approach to evaluating complex interventions in healthcare, which I think extends very nicely to well-being, because generally interventions are very complex in that arena. So essentially what's driving this is you've got a lot of lots of causal links in a complex system. So just measuring things is quite hard to do reliably. There's lots of confounding, lots of noise and drowning out your signal. So we've written a paper where we talk about ways of trying to tackle that problem and what you focus on and what you do. And one thing we thought would help for us anyway, and it was to try and classify your outcomes on 2 dimensions. One is causally, are they linked to... So I'm always thinking here in terms of change. So the idea is that we're looking here, where I come in is probably where you want to invest in something, a programme, or policy change, or something like that. So you're going to impact the system. What's the immediate consequence of that? So it's helpful to distinguish between proximal impact of what you're doing. So the immediate ripples around you, you intervene, you get these immediate ripples. They're very causally directly linked, so there's less chance for the noise to drown out your signal. Whereas the distal ones are, if you're intervening in a complex system, the things you're interested in may be quite far away causally. what you're actually doing. And the other distinction I've got is between what I call instrumental outcomes. They're things we're not necessarily interested in for their own sake, but we know that if we change them, we'll change the things we are interested in, which we call here intrinsic outcomes. So here's an example. Imagine you had an intervention to improve sort of the things like something around school-age child welfare. The immediate thing that you might see is school attendance. Say it's a truancy program. The immediate thing you might see happen is school attendance change, and I'm arguing here that maybe that isn't the main thing in itself you want to change, but it's the thing that you'll see change. So that's instrumental and proximal. The other thing that might lead to is better educational attainment. I'm classifying that as distal because it's a long, sort of like causally more far away consequence of improving, say, reducing truancy in this case. And also I'm arguing that there may be other confounding factors that mean you can't necessarily prove you've achieved that, but you probably will achieve it. But I'm calling it instrumental because I'm arguing actually, if you agree with that, I'm saying that actually qualifications in themselves are not the point. The point is that they demonstrate the achievement that's then useful to a person and to the economy and society. And so similarly, you've got, so if this is a well-being measure aimed at making children happier to attend school, I think that's kind of what I conceptualise here. There is an intrinsic subjective well-being, a concept I'll come back to, and that's, to me, we can and I believe should value for itself, and that may be a direct consequence of your intervention. You directly improve the sense of well-being of the children you're working with. And then distally, but intrinsic, this is linked to one idea is that you may say, well, if we improve this school-based environment long term, we're going to have people who are more successful, more highly skilled. That's great for the economy. So that's just an illustration of this kind of way of classifying assumptions, outcomes that we found quite helpful to then help develop some of that sort of modelling work I described and think about where you want to measure and where you want to infer. So the next point I'm going to come to is a bit of a bugbear. It's a bit of a sort of like a trigger warning for me. I've often stood up and then been introduced as the money man, which is wrong on several counts. Firstly, you can see from the whole of my jumper, I'm clearly not a money man. But also, there's one issue that comes up a lot, which is the fact that we're interested in priority setting and generating value, which isn't the same as cost saving, which is really unfortunate because that's the way the public sector gets, by policymakers and politicians, it gets interpreted. Totally wrongly, but that's the way it happens. So I'm not here to try and make people save money or to help people save money. We're trying to help inform decisions about where you prioritise your allocation of resources or inputs, as I call them here, by looking at the value that generates. And so this is the kind of space that I kind of do a lot of my work in, and various terms of this exist: return on investment, value for money, cost effectiveness, cost benefit. And particularly return on investment is probably one that you've seen quite a bit mentioned, quite a popular term in public health and public mental health and well-being. And this is the thing that I'm sure you've also experienced as well, is that the way it gets used by politicians, by managers and so on, is assuming that it's about cost saving. But actually, when we talk about return on investment, the return is the value. And people have written, there's a reference which I meant to put on there and I've forgotten. Sorry about that. But I'll provide references afterwards that I've forgotten to add. But someone from the King's Fund wrote a very articulate blog post basically explaining, we talk about this return to, say, investing in public health, public mental health, things like that, in pound terms. A big component of that is actually a non-monetary benefit that's somehow been valued in pound terms. So, it's important that we do, to recognise we do include that. We would want you to include that as an economist in your return on investment calculation. But B, you'd be sorely disappointed if you think when you see a large return on investment, £5 generated for every pound saved, if you thought that'd actually be hitting your budget as a budget holder, because it won't. It is actually about value, which is described in monetary terms, but it isn't necessarily money saving. So thanks for letting me get that off my chest. That's a trigger point. So the next thing I thought would be that we think about, which I thought might be relevant here, and it comes back to the issue of counting and measuring, and had an interesting conversation with Andrew earlier about sort of what gets measured gets valued, and that is a key problem. So one thing that I found useful is to try and distinguish these three different concepts that I mentioned at the start. Identify. So if we're doing this cost-benefit analysis, we're doing this sort of value case for something like a well-being intervention. Go through these three steps and think about them separately. So the first step is identifying where the impacts are. And that's important because if you go back to that picture I drew, they may be quite diverse and they may not be where you thought they were. So actually, although, again, in a lovely chat with Andrew earlier, I was talking about how we need to quantify things as economists. Actually, as always, you then have the counter, the antithesis comes out of it. Qualitative research to get that deep, rich understanding is crucial, and particularly with people with lived experience, because often you won't predict where the benefit is you're generating. So, for example, we did some work on digital health in terms of young people clinician interactions, and it was really fascinating to hear the things that really made a difference. This was, for example, young people with type 1 diabetes. Things like being able to go on school trips without worrying about the meal plan because they had digital contact with their dietitian or nurse. That freedom, that control over their lives, hugely valuable to them. And so identifying that, because that actually may be where the value will be generated by the intervention as much as any cost savings. So identifying that, making sure that you've got that identification from people with lived experience is really important. And so, and that's generally, and you need good qualitative research to do that, which is, again, outside my area of expertise, but I recognise the value of it, and so there's certain research methods you might use for that. But then separate out the measurement. Although we do need that rich picture identified qualitatively, we do need measures to try and make that value case, because, again, it's not enough to say we will do good, given that we're in this complete, sort of fight to the death with resources, particularly at the moment. You have to sort of be some sort of quantitative measure of how much benefit you're generating somehow. But that measure has to, I'm using the term construct validity, I may not be using it quite rightly. What I'm trying to say here is, it's not about measuring something, but thinking about using a measurement tool that aligns with that benefit that you want to capture, or that instrumental outcome that you think your intervention will generate. So carefully thinking about what the measure is as important as collecting the data, but usually that will be some sort of survey data. And then I'm separating out measurement and value, because you can measure, I've improved, say, so many points on WEM, so Wellbeing scale. So what? How does that benefit compare with, say, operating on 200 hips? So, because maybe that's I talked earlier about the kind of resourcing being, if you want resources, it has to be taken from somewhere else. The fundamental term of opportunity cost. So to try and understand that opportunity cost, to justify greater investment in the thing you want, you have to be able to sort of value the benefits to make that comparison. And that's actually really challenging. But there is a body of work within health economics that concerns itself with that, around what we call preference-based measures. And I'll talk a bit more about that for the rest of my talk. And I hope I'm going to time. I wasn't sure exactly how much time I have. If you'd like me to go faster.
No, you've got...
If you're getting fed up with me.
No,
do say.
This is really, really helpful, and I'd rather we took it at a gentle pace, because I'm taking quite a lot of notes.
Brilliant. Absolutely. That's really good to hear. And it's really great to have the opportunity to talk through some of these things that we think of and get your reflections. So, but if there's things you want me to skip over, we can always come back to another time. Do let me know. So that distinction, I think, is really helpful, because there are three different concepts going on there, which require different research approaches and different ways of thinking. But for the last bit of what I'd like to talk to you about today, I want to come back to this idea of intrinsic value of well-being. And one of the things, so the point here, the context of this is moving from physical health to mental health and well-being, and the world, so the policy world of public health, policy worlds of well-being, people can be quite, think of it instrumentally. It's like, yeah, but so you can improve well-being. What will that do for the NHS in terms of saving costs? What will that do in terms of, all those power slides I showed at the beginning? Yes, okay, that's fine, but actually, isn't it good that you've improved someone's well-being in itself? Isn't that something that needs to go into that cost-benefit equation? I strongly believe it does, and I think that's conventionally thinking in that. The question then, of course, is, well, how do you value relative to other things that well-being increment? And we often think here in terms of trade-offs. We always think in terms of trade-offs as health economists. But one of the reasons we get called the dismal science is because we're saying, but okay, if you want that, you'll have to give up something else. How much would you give up to have this thing that you say you value? And that's the way we think about value. And so one distinction we make is between revealed preference and stated preference. Revealed preference is where you look at what people actually do. And so you might look at decisions, are people, how much do you have to pay someone to take a job that's risky in some sense in terms of their lives or their health, or perhaps their well-being? It's a stressful job. And if you know how much people are willing to take, how much an employer needs to pay extra for that, danger money, that gives you a sort of crude way of getting at the value you place on that well-being or health loss you're giving them. Obviously, a huge debate about how reliable that is, but the alternative methods broadly are, you can ask people directly to either express value or willingness to trade off, and a lot of work in health economics has done that for generic health. So you may be familiar with things like the, excuse me, so the QALY measured with something like the EQ5D measure or the SF12. So people have made these things preference-based. I keep using this term. It basically means we've gone to some sort of trade-off thinking to give a relative value to it. So with an EQ5D, people have done some stated preference research to say, how much health improvement on the EQ5D are you willing to trade off for having a slightly shorter life? So let's trade off a shorter healthy life for a longer ill one. Where's your point of balance? And people have been through that exercise, and that's another way try and get to get that sense of value that we can then, as health economists, put into our little models to do that kind of cost-benefit analysis, but incorporate these vague, non-monetary but crucial impacts. So I've talked about EQ5D. That's kind of where a lot of the health economics, that body research, where it sort of come through. But as we've been criticised because of the use of EQ5D and things like that have been criticised. The problem comes back to this issue. I use the term construct validity. I may be using it wrong. I probably am. But essentially, it's this idea of is your instrument, your questionnaire, actually capturing and measuring the thing that you actually want to measure and value? The things like mental health, certainly, particularly severe mental health, serious mental disorders, a lot of evidence suggested it wasn't doing that at all well. So there are various ways in which health economists have extended that research. There's the use of the capabilities approach, so Amartya Sen's sort of ideas that we used to develop into a kind of measure that we could use for that kind of cost-benefit work. So there's a measure called ICECAP, which is broader and has some more validity in terms of mental health, and maybe captures well-being in a more appropriate way than a narrow health-based measure like the EQ5, such as EQ5D, for example. Another approach that I'm aware of and don't fully understand yet is, you may know more about this than I, is recently sort of what works well-being and the ONS have derived a value based on the statistical value of life for a 1-point increase in life satisfaction. So it's kind of the preferred measure, and I've got my views on this, you'll have your views, and I'm happy to be argued against on that. But the thing, so if I understand correctly, that there are people who are very keen on this sort of, is it like a 10-point scale that the ONS use, like how satisfied are you with your life? And that's seen as it's a 5-point scale that economists use, and a lot of the happiness research uses that kind of scale. And then you can put a value on a 1-point increase in that. My concern with that comes back to this idea, which I keep calling construct validity, maybe wrongly, but does that 10-point scale of life satisfaction actually capture the thing you're trying to improve? My concern is that a lot of times it won't, so then this would be useless, wouldn't it? If you're measuring a 1-point change in something that isn't changed as a result of what you're doing, but other things are changing, then you're going to massively underestimate the value of what you're doing if you just use this sort of life satisfaction measure. There are probably strong reasons to do it, so I'm not I'm not in a position to advocate for it, so I just can share my personal concerns about it. Because, and also I've got a kind of, again, I'm kind of totally biased here. This is total conflict of interest because a PhD student of mine, now Dr. Edmund Yu, we did this preference-based sort of trade-off exercise. He did for his PhD, he did that for WebWebs. So we can now, based on his work, he's basically created a tariff through interview-based trade-off exercises using what we call discrete choice experiments, which some of you may be aware of that methodology, where you choose A or B profiles. So he's done a large valuation exercise during the pandemic, so over Teams, to get a UK tariff for WebWebs, so to generate like a quali, but he called it an M-wally, but it does the same thing as a quali. And so obviously I'm a big, as a supervisor, I'm obviously going to push that one, because my argument is that maybe WebWebs is a better, broader measure of capturing the sort of things we mean by public health and mental health well-being than this life satisfaction scale. Of course, you may tell me, and other people may come along and say, well, there's better measures than WebWebs, and then you shouldn't use this work, which is fine. But I think the key point I want to make as I come to the end of my talk, so thank you for giving me the time to go through all of it, is this idea of finding the measure that captures what you're changing, that's the change you're seeing that people value. We can then use our techniques to mean that you can use that to capture these intangibles or non-monetary benefits within that cost-benefit analysis, so that they don't get forgotten, they don't get ignored. I think that's the motivation for doing all this research anyway. And I say it's quite a new area of research. I mean, this was like last year. We've just submitted this for publication, so there's plenty of scope to critique it and improve that research, make it more useful to you. So I hope some of this has vaguely overlapped with what you came here expecting to hear and talk about. But basically, I think the thoughts I've had that I wanted to express was first this idea that I'm interested, as health economists, I'm interested in trying to see, are we over-investing or under-investing in public sector activities that create well-being? I suspect we under-invest. So as a health economist, what can we do to show that? Part of it is capturing and inferring and modelling those the full gamut of those impacts that I talk about, so recognising that they're quite diverse, building them into our analysis to make sure that your intervention has a fair gets a fair shot. Also, we don't have to measure everything directly. Maybe we can think about mechanisms and a theory of change for what we're doing may guide us, and some of the thoughts about classifying outcomes that I discussed earlier may help us to think about what we measure, where we go measuring it, as well as rather than trying to measure everything. I'm not a money man, we're not money men as health economists, and when you see economic valuation, if it's done correctly, it isn't just about finance. So we do capture the intrinsic value of what we're doing as well as the financial value. Well, we try to, but it actually is quite challenging to do, as you can imagine. And I've just touched on some fairly recent research, but the idea is that we need measures that both capture that are sensitive to the thing you're trying to, the benefit that you believe you created, but also have this preference-based value, thinking about trade-offs, so you can actually then plug them into a cost-benefit analysis. Otherwise, you don't know, like a 2-point change in your scale, is that how valuable is that? When you make something preference-based, you can answer that question. So those are kind of my conclusions. Thank you very much for letting me get to them. I hope some of that will chime with things that you're interested in. I'm happy to discuss those afterwards. Thank you very much.